All right, we'll go ahead and get started with our webinar today. I'd like to thank everyone who has joined us today for the final in our 10-part series that the Oregon Office of Rural Health is hosting, focused on critical access hospital finance and operations. I'm Sarah Anderson, and I'm the Director of Field Services at the Oregon Office of Rural Health. And today's webinar is Fund Your Mission, Practice Steps to Move from Volume to Value. Next slide, please. Before we get started, I'm going to go over a few logistics. The audio has been muted and the video is turned off for each attendee. You can select the ellipses on the right of your screen on the bottom to populate the chat feature, and we'll use this feature to ask your questions today. And we'll monitor that chat and ask them of our presenter at the end of the webinar. You can also raise your hand by clicking on the bottom of the screen. There's a little hand button there, and then we can unmute you and you can ask your question live of our presenter. The presentation slides and recording will be posted shortly after this session on our website at the link on the slide, and I'll put that link in the chat in just a moment. Next, please. So as I mentioned just a moment ago, this is the last in our series of 10 webinars that we're hosting with a focus on CAH finances and operations this year. The webinar recordings and slides of all of the previous webinars in this series are posted on our website. And again, I'll put that link in the chat in just a moment. But I'd also like to note that we're going to offer another series focused on CAH finance and operations in 2024. So please stay tuned to your email inboxes for more information. Next. And with that, I am really pleased to introduce our speaker. With us today is Jonathan Pattenberg, and Jonathan is a principal at Wintergreen. He's an accomplished, results-driven senior executive with nearly 20 years of progressively responsible experience advising for-profit, nonprofit, and governmental entities. Over the past 6 years, he has worked with entities which range from independent practices to multi-state healthcare systems on how to leverage rural opportunities to improve financial and operational performance. Prior to that, Jonathan served as the Chief Financial Officer for a 21-bed nonprofit critical access hospital. I'd like to welcome you, Jonathan. Really thank you for sharing your expertise with us today, and I will hand it over to you.
Thanks, Sarah. I'm excited to present on this topic today. As Sarah had mentioned, we're really encapsulating all of the different things that we've presented over this past year. Now, when we talk about really moving from volume to value, oftentimes organizations will jump in and put themselves in a difficult position where they haven't really changed their organizational position, and they try to change immediately towards a value-based reimbursement methodology. Unfortunately for us as critical access hospitals, we are still predominantly reimbursed based on a fee-for-service reimbursement methodology. The proportion that we provide in services relative to our Medicare population ultimately flows through the way of cost-based reimbursement. So as we start talking about these things, what I'm going to highlight today are different things that we have to be focusing on if we want to consider changing to a value-based approach. Now, again, you can't jump straight to the end. As we start looking at all of these additional areas, we have to realize that as we start focusing on these areas, even if we start to change operationally, does not mean that the reimbursement methodologies are going to keep up with where we are wanting to position ourselves going forward. However, what we can start looking at, and it doesn't matter whether we want to dabble in ACOs, whether we want to try some of the alternative payment models, whether we want to try to push towards going towards full capitation or budget-based reimbursement. As we start looking at these different areas, we have to ensure that we start to operationalize the different components and put ourselves in that position to be successful. It will do us no good as an organization to transition fully towards a value-based model if we are still reimbursed under a fee-for-service reimbursement methodology, and then we only continue to jeopardize the services going forward or somehow put our organization in an unsustainable financial position going forward. So we have to look at all of these factors and start to position ourselves in those areas going forward. Now, as I've talked about before, and I know I've presented on this in the past, We have a rural environment, and what's unique about the rural environment is there's significant barriers and opportunities that we are positioned with that can allow us to more effectively position ourselves as an organization going forward. Now, even though 1 in 5 Americans live in rural communities, we do not see that same distribution of healthcare services across the country. Many of us still have to travel to urban communities to get access to specialty services, to get access to certain specialty providers, or to have surgical procedures or comprehensive care. Again, there is not that overwhelming reach in many rural communities to gain access to those services. Now, what are many of the barriers that we experience in rural environments? Again, it's a highly fragmented environment where, again, we may go receive services from an independent diagnostic imaging center. We may get our primary care services at an independent clinic. We may get hospital care at a hospital. Again, there are not those broad overlaps in a lot of these services because oftentimes rural communities do not have the ability or the sustainable volume to actually support multiple providers in all of these additional areas. In addition to that, we also are operating in an environment where there is complex regulatory and administrative rules that drastically dictate how we can actually perform services within that rural market. Again, I know we've talked about before, but I'm sure everybody on the webinar is aware of the change in, for instance, the RHC reimbursement methodology and going to an upper payment limit for our provider-based rural health clinics. Now, this is something that fundamentally changed how we are reimbursed as rural health clinics, and it'll change how we can continue to deliver care and the reimbursements we receive going forward. Now, what we also have in rural communities is even though there's unique barriers that we have to end up overcoming, there are a number of opportunities that we can look at as a way to further our position going forward. Whether we talk about the designation and alignment of practices, whether we talked about throughput, whether we talked about optimization of services or service expansion or expansion of swing bed services, there are several different ways that we can look at opportunities. Now, when we look at opportunities, it's also important to categorize them in different areas, particularly as we're starting to look at dabbling in, say, an ACO or some type of value-based initiative. As we start looking at those areas, the categorization of those different opportunities will allow us to identify and appropriately place those opportunities and determine whether or not they will impact us in a fee-for-service environment, whether it impacts us only administratively, or how all those things play out going forward. We have to understand this and we have to play into these different factors. Now, if we look over the past couple of years, particularly since the start and the ending of the COVID pandemic, all of us have experienced staffing shortages, revenue cycle issues, out-migration, cost increases. How we plan to operationalize these different components and how we plan to build upon these different opportunities will ultimately dictate whether or not we can be successful and sustainable going forward. It's important to emphasize that we continue to operate in an environment where cost continues to increase at a greater rate than reimbursements. And as we continue to operate in that environment, we have to look at different ways to start to drive revenue towards our facility. Now, as we start talking about some of these different value-based opportunities, there's ways that we can start to push ourselves towards a value-based reimbursement model without actually jumping fully in towards a shared risk or capitation or some type of extreme reimbursement model for our facility that puts us again in that unsustainable position going forward. Now, when we talk about the practical steps, I'd say the first thing is to really look at your organization, to identify the different opportunities, the ways we're delivering care, the potential for duplication or unnecessary services, or different ways that we can start to combat things going forward. Again, when we look at all of these alternative models, the goal of many of these alternative models is to reduce the overall cost of care by putting us in a position where we start to transition the healthcare from a sick care model more to truly a health and wellness care model. But again, if we don't start to look at those services in that transition, we will only start to pull volume out of our facility, which again can hurt us in that current reimbursement model. Now, the first thing that we have to understand if we're going to start looking at that transition from volume to value, we have to understand our cost structure. Only through the understanding of our cost structure can we truly start to know what is our fixed cost, what is our variable cost, and what can we truly effectuate change within our organization relative to a cost position. Now, if we are a critical access hospital, and let's say that our fixed cost, again, this is the cost to operate and to open our doors, regardless of any person actually comes to our facility or not. If our fixed cost is $10 million per year, in any of these alternative models, or even in a critical access hospital reimbursement model, we have to ensure that we turn enough profit and volume and revenue to sustain that fixed cost going forward. That is that bare minimum in that position. The second area is also covering the variable cost. Now, when we talk about the variable cost, these are the areas where we can actually effectuate change relative to our cost structure. Now, unlike our fixed cost that doesn't go up or down depending upon patient volumes and different factors, our variable costs are those costs that go up and down depending upon our specific volumes or the services that we are providing. If we were to look at the distribution for critical access hospitals, rural health clinics, other rural providers, upwards of 90% of our cost is fixed in many of these rural facilities. Really, only 10% of our cost can we truly effectuate change and try to cut cost going forward. Now, the reason why I emphasize this is because oftentimes when organizations start to go towards that value-based conversation, they try to look at what cost they can pull out of their facility as a way to cut that cost profile going forward. And again, for critical access hospitals, I want to emphasize you cannot cut your way to success as a critical access hospital. There is only so much cost that you can pull out of your organization before you eventually reach a point where you are deciding whether or not to terminate a program or to continue that program going forward. Now, when we talk about our critical access hospitals and we talk about our net position, there's really two inflection points for us as critical access hospitals. Again, our fixed cost starts at a point that doesn't change whether we have 100 patients or 1,000 patients. And that's that red line up on the screen. Now, as we continue to increase our volume, we can see the purple line continues to increase also. That is our variable cost that continues to increase as we increase our service volumes going forward. As we look at these areas, the key thing is that we first have to at least cover our fixed cost. Then we can eventually cover our variable cost. Now, the solver for us as critical access hospitals is always going to be volume. Until we fundamentally change the reimbursement methodology, volume will always be the solver for us as critical access hospitals. And the reason for that is the direct correlation between volume and reimbursements. Now, the way it broadly works for us as critical access hospitals is we take our fully allocated cost as a facility across each of our revenue generating departments, whether it's emergency department, whether it's physical therapy, or whatever else the case may be. And what we do is we divide that fixed cost, that fully allocated cost, and we broadly divide that by our volume within each of those different departments. Now, again, if we get at a very granular level, we worry about RCCs and the ratio of cost to charges across the different payers and across Medicare versus Medicaid and so forth. But again, at that high level, generally, as we continue to increase our volume at a critical access hospital, we will dilute down the cost per unit of service, which ultimately can allow us to get more and more closer towards a profitable position or actually achieve a profitable position going forward. Now, on the inverse of that, as we continue to pull more and more volume out of our facility, we are only going to increase the average cost per unit of service, which means we are only going to make ourselves more costly as a provider of care. And many of us have seen this over recent years, particularly around our swing bed services. Now, we may have a $2,000 daily rate, and many of us will have conversations with the Medicare Advantage plans where the Medicare Advantage plans will say, well, you're $2,000 a day, and I can send them to a SNF for $475 a day. So we're going to try to redirect them to that SNF instead of keeping them at your facility. Now, in that instance, again, as we pull out more and more volume, our rate's going to go from $2,000 to $2,500 to $3,000 and so forth. So what we have to look at doing as a critical access hospital to truly in today's times and under today's reimbursement methodology to be a more cost-effective provider of care, we have to look at ways to increase our volume relative to the actual cost at our facility. And doing so will dilute down that cost per unit of service. Now, one thing I want to emphasize also is that when we look at ourselves as a critical access hospital or even a rural health clinic, the only way that we can be profitable based on our net patient revenue is to drive the cost per unit of service, again, that rate we're receiving from Medicare, to less than what we are receiving from commercial payers. So long as we can continue to get higher reimbursements from Medicare at cost base than we receive from commercial, we will have to continue to make up that margin in other areas, whether it's 340B, whether it's tax subsidies, whether it's other operating revenue. So again, we have to start looking at ways that we can push more volume to our facility. Now, there's additional ways that we can push more volume to our facility in today's times and truly try to optimize within that environment. And one of those ways in particular is on our primary care or our outpatient services. Now, oftentimes, if we were operating, let's say, a rural health clinic and we're doing primary care services, many of us still continue to operate in an environment where we are only providing those acute care, primary care type services. How many of us are regularly scheduling our annual wellness visits or getting patients in there on a regular basis for follow-up and checkups? Again, these are ways that we can get more patients into our facility and we can look at opportunities to dilute down our cost per unit of service. We have to look at these as ways going forward to improve our net position. Now, a lot of these different alternative models really was founded under the concept of the triple aim. And I realize in today's times, this has even been expanded to the quadruple aim. But for the purposes of today's conversation, it's really under the framework of that triple aim. And it focuses on three critical areas: population health, per capita cost, and experience of care. Now, for years, we have always focused on the per capita cost. We've always looked at the cost per unit of service. How can we control costs? How can we reduce the cost of care and so forth? About a decade, we really started to focus more on the experience of care. A lot of us started doing patient satisfaction surveys. We started tracking certain metrics and so forth. Those organizations that are really leading the way relative to population-based initiative and these alternative models have really started to look at population health in conjunction with the experience of care and the per capita costs. Now, the broader IHI goal is ultimately to improve healthcare outcomes while reducing the per capita cost of healthcare within the United States. And again, when we look across that landscape, I can easily emphasize that the model that we have today is not sustainable in the long term. We cannot continue to experience the year over year cost increases that we experience within that healthcare landscape and expect to remain financially solvent or viable going forward. We will have to start looking at alternative models and methodologies as a way to sustain healthcare services going forward. I'm sure if I were to ask everybody on this webinar today, if you were to look across your rural landscape or look across the landscape of your primary and secondary service area, how many duplication of services do we see across the healthcare landscape? Have we truly started to focus on the integration and the reduction of unnecessary care and services, or have we continued to look within the envelope of care that we provide and ensuring that either our hospital or our system can provide those services going forward? We have to start looking at different ways to control that cost going forward. Now, when we look at that conceptual approach of what the triple aim was trying to accomplish, it was very much trying to transition the focus more on individuals and families. Again, getting away from the direct control of providers and starting to become more engaged with the patients going forward around the delivery of care to them. It was also looking at pushing more and more services to primary care and preventative site services. Again, if we look across the landscape, how many of our patients continue to use our emergency department for primary care delivery because we do not either have adequate supply of primary care, or they can't get into our primary care clinics, or they just look at it because it's the easiest place to get in with that emergency department. Again, these are the things that the IHI was starting to look at. We also have to look at cost control and an overall population-based health management system. And when I look at across the healthcare landscape, I know I've said this before, data is one of the most overlooked areas that we have as critical access hospitals. As we start looking at our organization and the services that we provide, we have to start drilling into the data to look at what services are we providing, what additional services do we need, can we sustain care, do we need expansion, do we need to pull back on services? We have to start leveraging this information to see what is the true need of our patient population to look at how we can continue to push things going forward. Now, the next practical step when we're looking at these alternative models is, I would say, to truly understand what are the different models from a reimbursement approach. And what I'm going to do is go through several of those models now. Again, some of them are more population-based focus, and some of them are straight on the reimbursement methodology that we have now. Now, one thing I want to emphasize, there is no perfect reimbursement model. Every single reimbursement model, doesn't matter if you're fee for service, global capitation, an ACO and an at-risk or shared risk model, every single reimbursement methodology has some pros and cons. The key is we have to evaluate the pros and cons relative to our patient panel, the services that we provide, the cost structure that we have, so we can ultimately determine what is the optimal designation and what is the optimal reimbursement methodology for us going forward. Now, the first of the models, which all of us are familiar with, is a straight fee-for-service reimbursement methodology. And this is what most of us are familiar with. Now, under a fee-for-service reimbursement methodology, we receive compensation for the services that we provide. If a patient comes into our emergency room, we bill for a technical component, we bill for the professional component. We bill for all of those services. There is a direct correlation between the revenue and the services that we bill for based on the services that we provide. Now, what are some of the pros in a fee-for-service reimbursement model? Again, it offers great flexibility. Patients can go out and get the services they want. We're able to actually encourage or incentivize the delivery of care by maximizing those visits and looking at different ways that we can provide services. It also holds providers directly accountable for the services that they provide. Again, many of us have seen from a minimum necessary standard or medical necessity or looking at all of these additional factors, if we cannot substantiate the services that we are providing, we are not going to receive reimbursement for the providing of those services. I'm sure all of you have talked about in revenue cycle recently about denials because a certain visit did not meet medical necessity. It also affords patients greater latitude to seek out the care that they want. Because again, in a fee-for-service reimbursement methodology, you're able to go to different providers based on the services that you need. Now, what are some of the cons of that fee-for-service environment? Again, it does not address potential duplication of services. It does not incentivize collaboration or working together. Because each provider is able to bill for the services that they provide, oftentimes we see patients just pushed in different directions because nobody is truly responsible for the outcomes for that patient. It oftentimes also leads to a very complicated system, particularly if you are engaged with a hospital that doesn't have all of those specialty type services. You may have to refer them to an urban area or a freestanding diagnostic imaging center or some type of freestanding physical therapy area. So again, it incentivizes some type of complex nature. It also incentivizes providers to start focusing on more costly procedures. Now, again, the goal is not to improve the outcomes. The goal is to generate the highest amount of fee-for-service revenue. That is one of the biggest cons within that environment. The next areas that we look at, and there's several ways to group value-based care. Now, there's four main types of value-based care, and this is where we're going to talk predominantly about the rest of the models. In the value-based care, you have shared risk, you have bundles, you have global capitation, and you have shared savings. Now, under a shared risk model, again, this requires organizations to keep cost below a certain point. Now, think of a shared risk model. This is kind of like your next-gen ACOs, where again, you have a limited amount of cost that you can incur for providing services. And if you go above that threshold, then you are going to have to experience part of the loss in revenue by actually surpassing what was your cost profile for your patient panel size or that population. Bundles. Now, in a bundle, this is where you receive a fixed amount of reimbursement for providing services to a certain patient. Think about these as like your total hips or your total knees, where it includes both the post-op, the pre-op, and also the surgical visit itself. We have global capitation. Now, I'm sure many of you have heard of the Maryland model. That was really the pioneer in this area. We've also seen the Pennsylvania model, which has gone towards a global budget-based reimbursement methodology. We're also starting to see other states start moving in that area also. And then the last is shared savings. And again, in a shared savings, this is exactly what it sounds like. If you're able to reduce the total cost of care for your patient panel, then you're able to share in some of the savings, whether it's a 50% share, a 20% share, an 80% share, or so forth. Now, as I mentioned earlier, each one of these models has certain pros and cons. I'm going to go through the pros and cons of each of these different models just to emphasize again. I've gone in and talked to many organizations before where they say, listen, we want to jump into a shared risk type methodology. And we've had conversations around, do they know their expense profile? Do they know what the cost of care is for their benefit or for their patients? And they don't have the basic answers to those questions. So again, evaluate all of your factors before you decide to jump into any of these models. Now, what are some of the pros of a shared risk model? It could lead to more efficient or high quality care to patients. The providers have a vested interest in the outcome of care for those patients because again, if you don't improve the outcome of the care for that patient, that may lead to more cost, which again may cause that cost profile to surpass that payment that you are receiving for that patient. It may reduce unnecessary services and it creates a focus more on population health management versus straight fee-for-service reimbursement or the delivery of services for each patient. What are some of the cons? Again, it can create an unsustainable environment outside of the control of the provider. Again, because the industry and our patient population has not fully transitioned towards a healthcare model, many of us are still living in an acute, high-cost environment. It's going to take time for us to be able to transition towards a true shared risk methodology because of the cost profiles associated with many of our patients. It can also create an environment where we are less likely to refer patients out of our network. Again, if we don't offer a certain service and we have to refer that patient to another provider, we don't want to send money to another provider that is not a part of our ACO or that shared risk reimbursement methodology. That's pure money coming out of our system. It also can change the focus to where we start making decisions organizationally as a way to control cost versus truly driving the delivery of care. And this is an example. I've worked with some next-gen ACO organizations where what they've done is they've looked at the cost of care relative to, say, swing bed or rural health clinics and so forth. And as those have gotten more and more expensive, because they were not aware of the fundamental principles applying to, let's say, critical access hospitals, as it became more expensive, they started pulling out more and more services from that hospital, which again only started to make them a more costly provider of care. Again, the cost of your critical access hospital remains the cost divided across the Medicare patient population, regardless of if you have 1,000 patients or 500 patients. Again, the goal is to drive volume to that facility, not to pull volume out of that facility. These programs are also administratively burdensome. Again, we've seen many organizations that have to track all the data and bring in an entire team of individuals to track all of the data necessary to effectively perform within one of these shared risk models. The next is around bundles, and again, most predominantly known as total hips and total knees. Now, what are some of the pros of the bundles? Again, can improve care coordination, offers greater flexibility in the scheduling and the follow-up of care. It can lead to the effective management of services within the bundle. Again, because you are receiving reimbursement for that total episode of care, you are going to want to ensure a positive outcome tied to the delivery of that service. It can also lead to administrative savings through the way of how we're billing and receiving compensation for providing those services. What are many of the cons of bundles? Again, in a bundled environment, you are not always clear of all of the services that are provided or included within that bundled environment. I was working with an organization out in the Midwest, and they were actually doing delivery services that was a part of a statewide bundle for Medicaid. Now, when they were providing those services, all of the services that were provided were actually included as a part of that bundle. But if this organization had actually worked with a rural health clinic under a critical access hospital, the cost of each one of those visits was subtracted from that bundle payment. So they had to pay attention to what was the cost that each one of these rural health clinics was receiving, because if they were providing services and that RHC had a $300 rate, they could eat up the cost of that entire bundle before they even got to the surgical visit. So again, we have to fully address and be aware of what is included and what is not. It can also create an environment where patients are unable to actually receive services because maybe the case is too complex, or we don't feel that the cost structure would fit within what we are going to receive as reimbursement. So again, high-risk patients may not be able to receive adequate access to care. The next area is really around global capitation, and this has been the most recent push that we've seen popping up across the country. And again, I've seen it in Maryland, we've seen it in other states, we've also seen it in Pennsylvania, we've seen Massachusetts start pushing towards some type of global payment for the Medicaid side. We are going to continue to see more and more states pushing in this direction, particularly for their Medicaid business, as a way to continue to control cost increases relative to that patient population. Now, in a global capitation model, again, it forces the direct alignment between provider and patient to improve the health outcomes for that patient. It can increase flexibility. It can actually lead to a capitated environment when you can actually start to more effectively negotiate with payers based on trying to receive reimbursement for, again, that patient panel size or that population. It also starts to focus more on the preventative services away from more of the acute care services. Again, in a capitation model, the goal is to try to improve health outcomes for patients so that we keep them out of the emergency room. We keep them out of needing surgical procedures, very much focusing on the improvement for those patients going forward. What are some of the cons of capitation? Now, again, in a capitated model, we may see patients get delayed in receiving care. Maybe you're pushing up on your upper payment or your cost profile for a patient and you're nearing the end of your fiscal year. You may try to delay care until next year to try to move it into the next budget year or the next cost profile. So again, people will start managing their cost relative to their budget versus relevant to the actual needs of the patients going forward. The relative risk to organizations can also be extremely high in a capitated model. Now, under the Pennsylvania model, when they originally pushed out that model, they established the budgets based on your cost at that point when you transitioned into that budget-based model. Unfortunately, the model didn't take into account future capital needs. It didn't take into account other parameters that could substantively impact reimbursements going forward. Now, if you were an organization, and let's say you were a rural health clinic, and you were having that $300 rural health clinic rate, maybe you had low volumes or you had high cost, your budget was set at that $300 threshold. You had a much higher or much easier chance to improve outcomes and control cost than that clinic that was turning a ton of visits that maybe had a $150 cost profile. So again, it was creating an environment where we started to reward those organizations that were more poorly performing in current times than those organizations that were excelling and were fiscal stewards of the actual revenue and the services that they were providing. The last of the value-based models is really around shared savings. And again, it's very much similar to what it sounds like in the title. Now, the benefits in a shared savings model is through a shared savings model, it may provide cost-efficient and high-quality care to patients. The providers are incentivized to improve outcomes and reduce overall cost for the patients. It can also diversify revenue streams. Again, because in a shared savings environment, instead of just pushing for fee-for-service revenue, we can start to generate revenue based on pulling out unnecessary procedures and costs from our facility. It also gets us to start focusing on population health management, again, instead of generating straight fee-for-service revenue. What are some of the cons associated with a shared savings? Again, there's significant upfront cost in implementing these systems. It could create an environment where, again, similar to the at-risk or the shared risk, where we're less likely to refer patients out of our network. It can also create an environment where we are not going to want patients with high cost in our environment going forward. Again, we are going to want those high costing patients in a non-ACO with a shared risk profile. We have to start looking at those and starting to evaluate those. Now, as I mentioned earlier, we have to look at what is the total need of our patient population, what is the cost profile, what are the services that they need going forward. This should be the first thing that we're evaluating. Now, what are several of the value-based care success factors? And again, I'm just going to emphasize some of these. There's several different success factors going forward. You have culture and leadership, you have provider strategy, and you have operations, technology, and partnerships. Now, when we look at provider strategy, what's extremely important around provider strategy is as we continue to change and as we continue to move more towards population-based initiatives, we have to ensure that our providers are fully aligned with how we are providing services going forward. For instance, let's say all of our providers are reimbursed based on work RVUs. How are we going to effectively transition towards a shared savings or an at-risk model if we are compensating our providers based on the number of services that they are providing? We have to start to have those conversations with our providers. So even if we are not looking at going towards some type of value-based model, we should start to realize that in today's times, we have to evaluate our contracts for our providers and start to position ourselves effectively. Gone are the days of just a fixed salary or a fixed salary and work RVU type contract. We have to start including patient panel sizes, patient satisfaction scores, health outcomes, and so forth as different ways that we're going to compensate our providers going forward. We also have to understand the importance around risk-based contracting. Anytime we are going to jump into a value-based initiative, it is going to fundamentally change our contracts and how we are reimbursed as an organization. We don't want to leave money on the table, or we don't want to incur unnecessary risk because we do not have that value-based or risk-based contracting experience. Now, this is not necessarily something you have to have in your organization. It is something that you can also contract with or find somebody at a system level. But nonetheless, when we are looking at these different areas, we have to understand the importance of these risk-based contracts going forward. I've seen organizations sign contracts where they have significant exposure and have not fundamentally changed their organization to put themselves in the ability to be successful going forward. As I mentioned earlier, data mining is extremely important. We have to leverage data that we have in our system, and we have to start making evidence-based, data-driven decisions as we continue to push ourselves going forward. Only then can we continue to remain in a solvent position. And again, the goal is to be able to sustain services going forward as we continue to provide these things. The last area I would say is really around financial literacy and modeling. Now, anytime we're looking at any of these value-based initiatives, we have to do our due diligence around financial modeling. There are different ways to calculate the net impact on reimbursements, the net impact on our financial position. We have to look at these areas to see what is the total impact on our organization. And will we be net positive? Will we be net worse off? How can we continue to structure these things as an organization to ensure that we can continue to provide services as a safety net provider? Again, I've seen organizations jump into these methodologies without having any comprehensive understanding as to how they are reimbursed and what that's going to do for their organization going forward. Now, another area we also want to have a broad understanding as a part of this clinical process is looking at clinically integrated networks going forward. Now, as we start looking at clinically integrated networks and looking at these different areas, we have to realize that there is a lot of duplication within the healthcare industry. And as we start looking at that duplication, there's the ability to pull out unnecessary cost and services as a way to improve our position going forward. Now, again, it doesn't mean that we need to be the provider of every service within our area. Just because a service is not provided under our umbrella does not mean that we have to be the one actually providing that service going forward. Again, start to look at how we can leverage other providers and leverage relationships as a way to improve our position. These are different ways that we can leverage things and start to reduce that cost burden going forward. We also have to look at the organizational components. Again, clinical leadership, information technology, oversight. contracting, revenue cycle. All of these are fundamental areas that we have to have that broad understanding. Now, as we start looking at these different incentives also, there's different ways that we can start looking at where volume is going and how it's playing within the industry. Again, we can start looking at referral patterns. We can start looking at integrated care initiatives. All of these are additional ways that we can start to focus on these fundamental areas. Now, again, as I emphasized earlier, do not jump straight to the end of a value-based model if we haven't started to operationalize these different components. We want to start looking at all of these additional areas. Now, when we start talking about different ways, I'm going to emphasize now a couple different areas where we can start to dabble in value-based outcomes or value-based care as a way to start to more effectively position ourselves, but not get too far down the road as to actually providing services or incurring a lot of risk as an organization. Now, I'm sure all of us have heard of what I like to kind of call the alphabet soup of care management services. We have our transitional care management, we have behavioral health integration, chronic care management. We have all of these different fundamental and functional areas where we can start to coordinate and collaborate across that healthcare continuum as a way to improve the access to care and start to improve patient outcomes going forward. Now, again, all of these are being included as a part of this presentation, so I'm not going to go over each one in much detail, because we have to start looking at the fundamental approach. Now, for us that are operating rural health clinics or primary care practices, have we started to look at different ways that we can start to become more involved with our patients? Have we started to look at care management services, whether it's chronic care management, COCM? Have we started to look at behavioral health integration? We have to start looking at the total area of healthcare as a way to start pulling these services going forward. Now, another great area that we can also look at, which I've seen more organizations start to dabble in, is as we start looking at these areas, and the reason why I always emphasize PCMH, our patient-centered medical home, is because these are areas or ways that we can start to jump into value-based care or value-based initiatives that does not require a significant or comprehensive change to how we provide services within our organization. Again, we have to track different data, we have to start looking at health outcomes, we have to start focusing on additional areas, but there is not a significant cost incurred with actually starting to focus on the PCMH concepts. In addition to that, I'm also not saying that we have to actually become PCMH certified. There are ways that we can start to implement the concepts as a way to start dabbling in value-based care and starting to get away from truly that volume-based care without fully jumping in and becoming a certified program or heavily investing in these additional areas. The key is to, again, to understand your functional position as to how you can start to position yourselves effectively for that transition from volume to more of that value-based care. Now, I know I went over a lot of this information today, very much at that 50,000 foot view. And again, the goal of today was to start to increase awareness around how we can start to transition or how we should start to think about that transition from volume to value-based care. Again, it's not something that we can just immediately jump into. We have to remain cognizant of our cost profile, the services that we provide, and all of those additional factors.
Thank you so much. That was a really great presentation, Jonathan. Appreciate it so much. To our audience, we're now entering the Q&A portion of this session. So please remember to enter your questions into the Q&A box, or excuse me, the chat box on the right-hand side of your screen, or raise your hand and I'll unmute you. I have one initial question, Jonathan. And I really appreciate that you discussed some of the strategies to incrementally move toward a value-based model. And I'm wondering if you have any examples, specific examples of really effective first steps that you've seen among critical access hospitals in terms of moving toward a value-based payment methodology?
No, and that's a great question. And even like an incremental cost, what we've seen organizations do, a nominal step you can do is just bring in a care coordinator into your rural health clinic that, touches base with your patients upon leaving that rural health clinic or that primary care clinic. What visits do you have that you have coming up? Can we help you schedule those for those services? Do you have any follow-up questions relative to getting care? Do you have the ability to actually get to that diagnostic imaging center to get those services? Or do you have the ability to get to? So start to have, that's something where you can bring in a person at a nominal cost that can start to engage more around health outcomes and the ability to provide care to that patient versus what we see in many primary care practices where a patient's just left to fend for themselves. They have to schedule their own appointments. They have to, follow up. They have to do all these things. Now, a lot of these things are mitigated if you're in a system relationship because you have central scheduling, you have a lot of these things. But when we look at these rural environments, not all organizations have access or the ability for those different services and care coordination. So I'd say this is something where we've seen a lot of organizations gain positive traction in that area. On the finance side, if you're a rural health clinic or critical access hospital, the cost of that position flows through your cost report, and then you end up getting cost-based reimbursed for it anyway. So it's something that you can invest in where you may only actually be subsidizing 50 cents on the dollar, and it can provide an invaluable service to that clinic and that community.
Great, thank you for that. And kind of a follow-up to that as well. And I didn't prepare you for this ahead of time, so sorry if you don't have an answer. But in the Medicare proposed payment rules for 2024, they're including care coordination, specifically among community health workers as now allowable item, and that also includes peer support specialists, as I understand it. And so, have you been seeing rural health clinics and community or critical access hospitals, rather, starting to invest in those types of relatively inexpensive healthcare workers to help in that movement to value?
Yeah, we definitely have. And a lot of times it's more the organizations that have started to jump into the PCMH or looking at those additional types of population-based initiatives. Um, we're also seeing a lot more prevalent in system-based organizations because a lot of system-based organizations are in some type of ACO or some type of shared risk, shared savings type model. It's we're seeing it less, it's less prevalent still in your independent hospitals and your independent clinics. Now, again, you do have your pioneering organizations that realize the value, or maybe they're a larger organization that has the ability to sustain those services. But it's definitely something that we're seeing. We're seeing a lot more clinics starting to bill for the CCM, the TCM. For all of you also, if we look at even the shortage of behavioral health services across the country, starting January of next year, we'll be able to bill Medicare for LPCs and LMFTs as an eligible provider. So the licensed professional counselors and your licensed marriage family therapist. So again, we're starting to see more of an expansion in what's allowed. It really just takes us to step out of like the day-to-day operational that we are all focused on, going from the issue today to tomorrow to the next day, to start focusing on those strategic imperatives to say, how can we start reinvesting in our community and trying to mitigate some of those other areas?
Great, thank you so much. I'm not seeing any other questions coming into the chat, so I guess we can move on to the next slide, which I believe is some announcements from us. So the first thing is, before you leave today, I want to point out that when you exit out of the webinar, you're going to automatically get a survey from WebEx, and we ask you to fill that out so that we can provide you this great content going forward and ideas for improving it. In addition, you have the opportunity to apply for continuing education credits by taking that survey. Secondly, I want to announce that October 11th through the 13th, the Oregon Rural Health Conference, which is our 40th anniversary conference, will be held in Sun River. And there is a registration link on the slides, which I'll send to you here in a couple of days, and are also available on our website. And in addition, to help celebrate our 40th year, we're looking for stories from your community to highlight at our conference. And we really want to make this about the rural healthcare facilities that we support through our office. And so there's a link here on the slide to tell us your story, a short story about how your organization has been advancing healthcare in your community, some, great milestones that you've reached and those sorts of things. It's very general, and we'll post those up on little placards throughout the conference. Next slide, please, Jonathan. And this is just a thank you to all of you for attending this webinar, being with us throughout this series. Please remember, as I mentioned earlier, we are going to offer another series starting in 2024. So please stay tuned to your emails for more information about that. And I want to thank you again, Jonathan. Really appreciate you being here.
No, definitely appreciate the opportunity. Again, if anybody has questions, please don't hesitate to reach out to Sarah, to me, or anybody else. The goal is to get you information and to help you further your position and provide patient care.
Thanks again. And I am going to stop the recording.